All right, so I just wanted to give a demonstration on how I do an incision and drainage. There's certainly multiple ways to get things accomplished. This is one way that I've kind of found to be beneficial, and learned some tricks to the trade, so I figured I would kind of pass them along. So right here we have a laceration tray. In most of the emergency departments, you're actually gonna have an I&D tray. So I kind of created this. So what comes in an incision and drainage tray is typically a fenestrated drape. You will have some gauze, but not a lot. You might need extra. You will have an 11 blade, you will have a hemostat, and you will have forceps. Rarely do suture scissors actually come in an I&D kit. So that means that you have to, typically use the 11 blade unless you're going to kind of go and grab additional suture scissors, which really is kind of a waste of materials. You do need something to irrigate the wound out with. You will need something to anesthetize the wound with. So this is 1% lidocaine. Rules follow. So if you can use epinephrine based on where you are on the patient, then for suturing, then you can use epinephrine for an incision and drainage. The other thing that you have to pick is you've got to have to go ahead and pick what type of packing material that you want. So if you want packing material, sometimes it's plain. Sometimes this comes as iodoform. Basically, it's impregnated with iodine. So again, check those allergies for your patient. Typically comes in 3 different sizes, and the sizes go to the width. So 1/4 inch, 1/2 inch, and 1 inch. And honestly, sometimes you just pick what you can find, unfortunately. If you want to do the loop method, which we'll just demonstrate today as well, this typically comes from the operating room. This is also a vessel loop, so we'll be using these when we go through our OR lectures in the fall. Sometimes the ERs are starting to have it because a lot of my attendings actually like the loop method, so that's why I wanted to demonstrate with that method to you today, just so that you know what you're getting when you go on rotations. And the other fun thing that I love to use that never comes in your kit, cotton tipped applicators, okay? I'll teach you kind of how this is so much easier to put the packing in if you're going to use packing rather than trying to use the toothed forceps. I just always feel like the minute I get a little bit of the packing material in and I use the tooth forceps, the teeth grab the packing material and pull it right back out. So I've figured out how to do it with a cotton tipped applicator to where it actually stays in place. So of course, I've already talked to my patient. They're in horrible pain, right? Yep, an abscess always hurts regardless of where it is on the body. They've tried 500 things at home to try to get it to pop before actually coming in to see you, right? So I've washed my hands. They know what we're doing. They've consented to the procedure. They know that they're not gonna like me. They're gonna like me in about 48 hours after the bulk of the infection is out and after the antibiotics have started to work. I typically will use adjunctive antibiotics, but truly the literature shows you that if you just use antibiotics and if they have a true large enough abscess, they have to have an incision and drainage, and I would go along and say incision and drainage and debridement of that area. So this is our abscess here, and we're just gonna go ahead and get this patient prepped, right? So I'm gonna have a chlorhexidine here, right? So we're gonna open up our chlorhexidine. We're gonna activate the material by clipping it. Chlorhexidine comes as 3 different colors. This is clear. Chlorhexidine also comes as orange, and I'm gonna use both sides of this abscess pad just to show you both areas. Comes as orange and comes as blue. Chlorhexidine does not need to be washed off. As a matter of fact, chlorhexidine has an antibiotic property to it, so please do not wash it off. Alternatively, you could use betadine for this patient, but then please, again, remove the betadine, right? I have a 5 cc syringe, so we're gonna draw up our anesthetic. Again, I'm typically one that will use just typically 1% lidocaine. This is our 18 gauge needle. You do not need a filter needle unless we end up having, again, where all of our lidocaine comes in ampules. Most of the time, this is going to come in a vial, and this is what you're gonna practice in lab. So we just take the cap off. And plus or minus as to whether you have safety needles or not. Some needles come as safety needles, right? Just making sure that you're actually in the anesthetic, inject all of the air in, and then just easily draw that back, okay? Obviously, this vial's been used before. Don't do that in real life, right? Conservation of resources, right? Activate the locking mechanism if it is on there, right? take that needle off, throw it in the sharps. You can use a 30. You won't find a 30 in the emergency department. You can use a 27. I typically will use a 25 gauge. I think it's better to deliver, you're trying to deliver a medication into an area that's already so edematous and thick that sometimes a 27 gauge, you try to push it and it just won't give you any like of the anesthetic going into the wound. A 25 gauge, because of it being larger, it's gonna not give you that same resistance. So again, take your needle off. You've already cleansed both areas, right? So I talked about two things within the lecture, right? The dome method. So you've palpated this previously before you actually cleansed it. And so you know that area right there that's sitting up nice and proud, that is the most superficial part of the abscess. It has the thinnest layer of tissue. So I like to go right into that area, and you're gonna feel the needle just pop right into the abscess, right? And you're gonna draw back a little bit, and then you're gonna just basically push that fluid in, okay? Why does that help me? Because just like how that dropped out, if that was an abscess that had not opened yet, right where that fluid comes out, that's exactly where my 11 blade is going in, and it makes it just easier for me, okay? So that's kind of the dome method. Again, it's gonna hurt the patient. You're instilling more volume into an area that is already hurting. So oopsie. Okay, I'm going. Minus my hand. You're instilling fluid into an area that's already hurting, okay? Now you can do the circumferential method, okay, all the way around. How do I do that? Typically bevel up about that 15 to maybe 30 degree angle. Just kind of drop your hand down a little bit. I will put the needle all the way into the wound, okay? Draw back a little bit, and then as I pull back, I'm gonna anesthetize that entire essentially quadrant of the area, okay? Now you just came out of here, you've got a little bit of anesthetic effect actually on both ends, right? So you could go to either side, but you basically walk around the wound, kind of in a box-like fashion. Pull back, anesthetize. My hand was up there because I had to figure out how much time I have left. And go to the other quadrant, drop it down, pull back, anesthetize as you pull out. Ooh, okay. This person's gonna be really anesthetized. Pull back and anesthetize, right? Again, you wanna basically get the anesthetic all the way around all four sides of that area. Scoop your needle if you need to recap it, okay? Don't ever push on the end, please, okay? I stuck myself one time that way, so don't do that. Click, take this off. You can keep this syringe though, because you can actually use this. Number one, you can use the rest of the lidocaine. I'll teach you a little trick about that. And you can also use this for your irrigation, all right? So two ways that you can actually use that. We're gonna essentially open up our I&D tray here that we've created, okay? I have a fenestrated drape. Again, you can really drop that there because nothing about this is sterile, okay? This person is very infected. You are actually making them better, right? So we're gonna open up our fenestrated drape. We're gonna place that on the wound. We can move our equipment right into this area. Let me tuck this back just so y'all can see. All right. And we've got our saline, right? So somebody can actually dump this kind of into cups on your field, or you can just use it straight out of the bottle, just like this, all right? So we've got everything set up for our patient. Our patient is as anesthetized as they're basically going to be. But again, if you did it my way, you have that little dome coming out so you know exactly where to go. So what do you do next? You use your 11 blade, okay? Now, remember when you're making a cut, right? You hold the tissue and you make the cut. For a I&D, I go straight in. So if that was exactly where I saw the fluid coming out, I'm not gonna cut, okay? I'm just literally gonna take the width of my blade and I'm gonna go straight in, okay? I hope that maybe demonstrates it. So again, straight into the wound and come out. What you're trying to recreate, this packing that we have is 1/4 inch packing, right? So you need to have enough of the width of the blade so that your packing can actually go in easily. So if all you had was 1 inch, okay, well then you're gonna kind of go in and maybe pull down and cut a little bit more, okay? Again, you can always use the blade again and kind of go back and make that incision longer if necessary. So at this point, it's the abscess is released, okay? You basically have purulent material coming right out at you. Makes it very easy. So what do? I typically will take a gauze, I kind of roll it up, and I just kind of roll around, and I roll around, and I roll around, okay? Kind of pushing all of that purulent material toward the center. Another thing that you do, you have a hemostat, okay? You basically go into the wound and open, and then you want to come straight out, okay? You don't want to, whenever you're going into anything, maybe this shows it better, you want to go in, spread, and come out, okay? If you go in, spread, and clip, what if you actually like clipped through tissue, okay? So you want to go in, spread, and out, and back together. In, spread, out, and back together, okay? So poke, spread, poke, spread, poke, spread, kind of getting all that purulent material. May want to go back in with another piece of gauze then, and kind of again push from the indurated area to the fluctuant part, to your opening, okay? Push all of that thing out. I will typically give my patients a countdown. Okay, you know, it's like delivering a baby. I'll give 3 more pushes, right? So I'll typically tell them that because it's very painful for your patient. You've picked your iodoform gauze. You want to cut once, okay? And only have 1 tail coming out of your patient, right? So I typically will cut long. And again, if all you have is your 11 blade, you're basically going to put the gauze down, wrap the gauze around, cut away from you, right? So we always cut away from us with regard to this. Put your blade back in your kit. This is where the Q-tips come in. So if you were to just use your pickups, you could, okay? You can use your pickups and kind of push that material in. But again, my experience, unfortunately, is that always these are like I push in and then it never it always pulls back out, okay? So I figured out the Q-tips really work well. So I take this and I typically will make it kind of very small and I put it right at the wound. Again, none of this is gonna be sterile. And I twist. And then I come out and I pick up more and I go in and I twist. I come out and I pick up more and I go in and I twist. And I'm basically twisting it into all of those little areas where the purulent material came out of. Don't overpack, that causes necrosis. Now look, I've got all this extra, right? Do I really want to leave this extra tail? No, but you cut long because you can't have 2 tails coming out of the patient. You can't have 2 pieces of iodoform packing, right? So you take your blade back, cut, leave a little bit of a tail, take the rest away. Now we're going to cover this with gauze and put some tape on the patient. One of the dressings I absolutely love to use on patients, I know this sounds kind of crazy, is maxi pads, okay? Especially for like pilonidal cysts that are on the backside where people are hairy, where there's all these kind of indurations of the tissue. Just have them put a maxi pad against their underwear, and as long as they're wearing tight underwear, it actually sits nice and securely to their body. And then you just tell them to change it as if they're having a period. Change it every 4 hours. It's a nice clean dressing. Packing should be changed about every 2 to 3 days. And again, at Lee Health, probably other facilities as well, we can refer them to complex care. The next video we're going to go over is going to be the loop method. It'll be shorter. I just want to show you the loop method.